Look, thank you very much for having me, and I see my co-conspirator in crime there, Kate, is there as well. Look, the thing I actually, given it's a Friday afternoon, I'd just like to acknowledge the pretty amazing 8 weeks that you've all had, because you've seen over 400,000 people through your EDs in the last 8 weeks. That's 44,000 more than the same time last year, so if you're feeling exhausted, I'm not surprised. So I'll just show you a little graph of that in a minute. Thank you. So there you go. So you're all feeling exhausted? So the other thing is you've done that and you have managed to still 92% have been offloaded, so you've kept all your transfer of care done in 30 minutes, 92%, best result ever in 16-17. And 72%, I want to get the exact figure there, 74%, sorry, you've got through the ED within 4 hours. And you've had nearly 8,000 more additional ambulances coming to your EDs. So I just wanted to say thank you and acknowledge that amazing effort. So with that note, I also thought you probably wonder how busy the system is on every day, and I don't know if you've seen this as well, because you're at the pointy end, and this is sort of what's going on in the rest of the hospital behind you and in front of you. So that's just another example of how busy the system is. And I think when we start thinking about things like better value care, a lot of the reforms that we talk to you about, that we do acknowledge that you're busy people and you've all got your day jobs. And so things like better value care are really taking what many of you are doing already, and it's about trying to make that business as usual, and I think that's a really important thing as well, that we do acknowledge that. I started working in health in 1985, so I'm getting a bit old now. And just the change in the system since I started in health all those years ago is extraordinary. So I think what we're really identifying here is what the Secretary has said are really the system priorities for her. And you can see that there's patient safety first, there's the leading better value care, which is number 2 up there, systems integrating, so bringing all those systems together, the digital health analytics, how we harness that and make that actually help us do our business and provide care to patients, and strengthening governance and accountability and getting that right so that it's right for the system, it's not over-governing, it's not asking, and getting in the way. So this is Elizabeth Koff, our Secretary. I'm sure you've probably seen her in many forums. And really what Elizabeth's view is that everyone's been talking about value-based healthcare in many ways over many years. It's just about patient outcomes, it's about patient experience, about how clinicians do their work. And so it's really, I guess, bringing that together as a concept and an approach that's time really has come. And it's actually about understanding, and you can see the quote up there, and yes, that is the experience and health outcomes of patients, and it's constant improvement, but it's also the experience of clinicians in that system as well. So again, this is, the policy framework. We always like to put these reforms in a policy framework to make sure that we cover all the aspects that we're looking at. And you can see quite clearly the patient is being put at the centre of this, and then it's really lining up all the players and all the other moving parts of the system around that patient. And so you've got all the delivery organisations, and there's lots and lots of people in that, as you all know. How do we harness, in the future to get some of those relationships even stronger with our, primary health networks, the general practice and our non-government partners? It's about benchmarking research and tools. How do we get that information out to you? Payment models in the future, and I don't want to over-emphasise that, because payment models and how we pay people for the right care is really that conversation about not just paying for throughput, not just paying for volume, but actually thinking about the outcome and what we really want to deliver. And again, how do we get the right information to who needs to be getting it to improve that care? And that's to patients, that's to clinicians, that's everybody to make that work better. So a lot of people talk about the triple aim. I guess we've moved that on a bit, so we say it's derived from that. And that's about health outcomes, obviously, and getting what matters to patients. The experience of receiving and providing care, and that's what I alluded to earlier, that's both patient, carers and clinicians. And there is that efficiency and effectiveness lens. That is part of, the picture in relation to this agenda. So what is it? So leading better value care has been defined and designated as a program. And that's to give it attention, that's to give it profile, but really, if I think about it, it's something that everybody does every day of your work. No one goes to work thinking I'm going to give a patient not good care. You're not going to go to work thinking I'm going to give low value to someone. That is not what people get up and go to work to do. So it's really something which is giving it a profile and an attention to put some focus on it so that we can actually, implement in a very systematic way ways and organisation of care that actually we know have a positive impact for patients and the system and their experience. And that there are opportunities to reduce cost or increase the return on our current investments. And that's to reinvest into health. So it's really about creating shared priorities. And I think that's also important to be across the system. I hear a lot about that LHD does X in an unbelievably good way. How come that LHD doesn't? So it is about sharing that and getting that and making sure that patients and clinicians across the system have access to the same levels. That's that equity type approach as well. And it's also recognising, obviously, those relationships into the primary care setting. And you'll see some of the eight, how they obviously, it's about the continuum and across from primary right through to the complex care. So it really has been an initiative that's been established. As you can see, it's one of the top 5 strategic priorities for the Secretary for the system. Like all these things, we have a steering committee which we report to, and that's with our central office colleagues in Treasury and Department of Premier and Cabinet. And we work with them in terms of reassuring and working collaboratively with them that the health system is doing its bit in terms of continuing to look at how it can improve. So the key goals of the initiative are there, that we focus on patients, and that's bringing in patient experience and the health outcomes. So that's all that PREMS and PROMS discussion that you're probably hearing across the system. There's a focus on value across lots of dimensions, so we've tried to make that broader than it has been. And it does really have to address future demand and fiscal pressures. And for you people that have dealt with, as I said, over 400,000 more people in the last 8 weeks, that comes at a cost. Demand in health is elastic, and the population growth and ageing only will grow. And so, of course, we have to look at what can we do with the amount of money that we've got. So really, what the opportunities from the initiative are, I think, is to build on the efforts of everyone in the system about providing the best care for patients, to really reframe our system as a world-leading, sustainable, patient-centred. They're all good words, but I think they're things that we really believe in and really want to deliver. We focus on the things that matter to us. That we, I think, accelerate where we know things are working and we know the outcomes are good. How can we accelerate that? How can we embed those sorts of strategies in the system? That sharing of priorities again, and understanding variation. And I think all variation is not bad. I don't know if anyone read Ross Gittins yesterday in the Sydney Morning Herald when he was talking about the banks, and he had some very interesting things about, everyone goes on about what you can measure, but be careful because it can take you, if you just look at data without substituting it for thought, you're going to make some very bad mistakes, as we can see with some of our banks. So I think that's actually about understanding variation, because not all variation is bad, and then addressing where it's unwarranted. So I think that's an important dimension in that as well. So what are the challenges that we've got to do? I think part of this is the strategic vision, committing to it and investing in the analytics that actually support that. What are the right drivers that we need in the system? So that does mean that we do have to look at things like purchasing, how we purchase services, how we evaluate, how we monitor, and how we actually put the right incentives in place. You know, what do we need to do? Because there's lots of things that are outside our control, but how can we partner with people for the things that we can't control outside the system? And I think most importantly, and part of the reason why Kate and I are probably going around many places, is that it's not about saving dollars. I know that I think this is being recorded. I think our Treasury colleagues might think it's all about saving money, but it's not. It's about doing things better. That is not the reason, the driving reason for why we're doing this. And I think that's important. So the three domains we've got better healthcare, we've got strategic commissioning contestability, and that's not code for privatisation, by the way. Commissioning is about understanding outcomes and how you're going to get there. That's what commissioning is. It's about purchasing the right thing and knowing the outcome. So I think that's important as well to realise. And obviously the workforce capacity. So they're the three domains we've looked at. And then these are the 8 that sit under better healthcare. I don't know if any of you are familiar with those. And there's 7 that are being partnered with ECI and 1 with CEC. So that's the 8 there. So again, this is about identifying areas where there was opportunity to work on models of care that were either in existence and to deliver better outcomes. So an example of how they'll work through. So ones where there was robust evidence, so things like the osteoarthritis program, osteoporotic refracture, renal supportive care, high-risk foot services. That was where there were already clinicians had done an enormous amount of work and had models of care in place, and they had been working through that. There was actually enough evidence where we could do good evaluations. There was, care that we could put in different settings and preventing hospitalisation, and so we could do economic appraisals to get an understanding of that. There's a second group where we know there's some variation that's happening in outcomes and patient there's a patient safety lens. And so really what we really want to do with these ones in the next 12 months is actually understand that cohort. And diabetes is about insulin management in hospital, so it's not diabetes in its totality. So again, it's scoping that back and really understanding what's the thing we're going to drive there. And the other issues that we looked at when we looked at that were things that were scalable. So there was no point picking of something that was really micro in Far West LHD, which was irrelevant for everyone else. So we had to think about that and how we scaled it and how we had a big enough cohort. So the way we work through one, I hope I'm not stealing Kate's thunder here, is, you can see where there's been an enormous body of work to do this osteoarthritis program. So we could do all these things that showed there were, 11% of the cohort could avoid knee replacement. So, and there was good evidence about, what are the improved patient experience and outcomes that we could get. So you could do an upfront economic appraisal, and we could use that in the formative evaluation, and we were able to provide that to government, and so we think we've actually got something here that we could build on. And we were able to do an evaluation of plan that started bringing in other things other than just efficiency and dollars saved. So we could bring in those outcome measurements, those experience measures as well. So where we're up to with the LHDs is really building on the efforts of New South Wales clinicians to provide care. All those 8 initiatives, sorry, I'm recovering from flu as well. All the 8 initiatives are being implemented during 17-18, and we're going to be looking at priorities for some implementation in the 2 6-month tranches. And we've had a lot of input from the LHDs to help us with the cohort data to help localise those approaches. I'm assuming you've all seen your service agreements for 17-18 with your local health districts. If not, they should be on the websites of those LHDs. So in the service agreements, those 8 are in those, and there'll be effort by all the LHDs in delivering on those. There was some extra funding that went out as either what we call, the NWAs, or some commissioning. So each LHD did get some resources to assist with getting these going. And we're obviously doing a number of visits and communications and engagement with people around the system just to talk about measurement, evaluation, and obviously the pillars are supporting implementation as well. So measurement's a really key part of this, and the approach with measurement is really about focusing on what we should be measuring rather than what we can measure. And we're okay that everything we should be measuring we might not be able to measure at the moment, but we want to make sure that we set it up so that we can get there when those measures come through. So we're not expecting everyone to be out there collecting everything day one. I think these are some, I don't know if you've seen this King's Fund information as well, which is about getting it right first time. And they were quotes from clinicians about, having to go and find information in a whole variety of places, when in fact if you could have it somewhere and use it once and not have to be going hunting around to what you're trying to find, how much easier it would be to actually, look at what you were doing. So, it's a very complex slide, I know, but you don't have to do anything specific. All these are data sets that we already have in the system. So it's actually about how do we harness this and how do we link it. So that's what we're aiming to do. So there's no, no one has to go through and look into the 50,000 patient records over there for osteoporosis. There's already rehab information. So it's about how do we actually collect and get this information as part of normal business. So all that information that's already been collected in the system. So again, how we want to keep talking to people and engaging with the system is really about continuing to work with the LHDs around the detailed data, look at local decision making around the priorities for implementation in those two tranches, continuing to work with the service agreements and the service agreement discussions and negotiations with the LHDs and the ministry there for 18-19 is starting now. So that's a very long-going iterative process. We're going to continue to talk a lot with LHDs and the system around how we get all that measurement aligned. Of course, Treasury and DPC are pushing us for the next tranche when we think tranche 1 with that 8 is pretty ambitious, but we're looking at tranche 2 and some of those things in that. There's hip fracture, for example, in that group, and bronchiolitis, for example, in those. And then we'll keep talking through the evaluation and the analytics, how we do the implementation, monitoring and reporting, and again, that pillar implementation. So, where we're up to and where we're going next is that all your chief executives have had correspondence about it, about the funding and the measurement approach. All those 8 have evaluation and monitoring plans, which have been finalised. We're now looking at developing the systems and the linkages to collect that measurement data that might not be so readily available. And we're commencing and doing our baseline collection that we've already got in place as part of the evaluation plans. And then we'll start bringing all that together in that measurement alignment framework, and that's really bringing everything together for that. We've had some, as I said, we've been through a process of calling for submissions for tranche 2, and we're just working through that now because we are conscious about how we're going to manage that volume of work in the system. And then we'll feed that, what we have to do is go back to the Expenditure Review Committee of Cabinet, which is a government committee, and we have to report back about how we're tracking in that. And then we'll be obviously there'll continue to be workshops around things like how we're going to look at doing in 18-19 and getting some consistency and shared vision around patient-reported measures. I think there's lots of differing views, so we need to understand exactly what we want to achieve in that. So, have I worn you all out on a Friday afternoon? You probably all had enough. Oh,
thanks very much, Catherine. It was a wonderful insight as to what's happening in the machine. And has anyone got any questions for Catherine there? Jackie?
Hi, Catherine. I'm the director of a rural ED.
Yes.
One of the difficulties, and I trained and grew up in the New Zealand system, so I've spent my whole career with the understanding that finance is limited, so I totally and utterly get that and I'm on board with that. But one of the things that's really difficult in the current climate is that there's often competing priorities between clinical priorities and money priorities. There's a situation in my department currently where something's being suggested that is financially probably good, but not by a great deal. And it's only financially good because it shifts the funding from one pocket to another. So in the big picture, if you take the whole story, it's not actually financially helpful at all. It just is helpful for our district. But it has a big clinical downside. And I'm being put in a very difficult position of being told, well, this is going to happen whether you like it or not. And I'm saying, I've got a patient safety problem with this, and you're going to tell me I'm accountable for this, and I'm telling you I don't think it's safe. How would you advise us to try and have those conversations in a way that's useful to both sides? Because I think it's really hard when the clinicians are on one side and management on the other to actually even sit down and have a conversation. Do you have any advice with how we have that conversation?
Yeah, I suppose it's not really in the context of better value care, because that's that program, but it is in the context of better value care and safety first, so I know what you're saying. Look, I've found that if you can have the conversation where you sit down with your management colleagues and have the discussion in a context that, yes, I know resources are limited, but there is still a need to provide safe and high quality care. And I can say to you, if you've managed to do treat that many more people in 8 weeks, the system does have the flexibility to flex up and down. And if you do the work, and everyone's got to live within a budget, that is a reality, but if you do the work, you do get paid for it. So it might be who's paying for it, so I assume that might be shifting things maybe into a Commonwealth bucket or something, or, yeah. So, but everyone is conscious that you don't do perverse things because of the funding, and that's part of the underlying principle with better value care as well. It's actually don't do perverse things because you think it's about saving money, and I think patient safety, if that is compromising patient safety, then that is absolutely a conversation that you need to have with the management people, because that, I guess, I don't think that's the right result. And I know that hasn't answered the question, but I think all you can do is sit down and actually have that conversation with them.
Yeah, it's just in the current climate, very, very hard conversation to have, because for me the concept of better value care is about using the money you've got wisely in order to get the best outcome you can with the amount of money you've got, not shifting the money from one problem to another problem and then saying, oh, well, good, I'm not paying, so it's all good. No,
that's exactly right.
And I guess that's the difficult thing is, how do you have that conversation? Because in the current climate, and we're in one of the districts that's pretty under the radar financially because the finances are bad, it's a really tough conversation to have, because it's hard to say, I can tell you that the clinical care isn't going to be as good, because until somebody does it and it fails, you don't know that for sure, although it's failed in other sites, so that would be a good indicator. Yeah, I was just wondering how you even get that conversation to happen.
Yeah, I'm sure there would be something, though, that if you looked around, I'm sure that there would be something that you thought, I could do that better, or if I didn't, I could do that more efficiently, or...
Absolutely there is, but that's...
and that's why
not
there's a bit of
necessarily the same priorities that that the people making the decisions have, which is very difficult. The clinicians don't seem to have a really good voice at that conversation at the moment, and I guess that's what I'm trying to say is, if you want, I firmly believe in better value care, and I think we're wasting money left, right and centre, and I've never seen so much money in healthcare as New South Wales has got, and yet we're squandering it. So I'm a total believer in doing it better and cheaper, but I'm not a believer in doing it cheaper and worse. Yeah. And yeah, there's a real disconnect at the moment in some services, I think.
Yeah, okay. And I think that's part, I would hope, with Kate, and these are the sorts of conversations that you can start having, because, you know, they are 5 strategic priorities which are about patient safety, better value care, and that's really the ability to go and have those conversations, sort of saying, well, I know that maybe it doesn't fit in those 8, but I can actually think I can do something better in this, and can I reinvest that to do something that I actually think's going to lead to better care? So it's a reinvestment, it's not just pulling it out.
Yeah.
Hi, can I ask a question? I'm very new to management and understanding any of the kind of big overarching policies which govern a lot of what I do as a registrar in emergency. If I were to take something back to emergency, and to all the other junior doctors and to patients and say, what does this policy mean for them, what can I tell them?
It's actually about the patient outcome and the experience and the clinician experience. So this is actually about what you're doing. As I said, to me, the message is it's not something startlingly new and different. It's about that sort of conversation which when you look around and you can see that you can do things better and that you want to deliver the right care, that's what it's about. It's about identifying those opportunities.
And what does that practically mean?
Well, that means, so we know if you can manage your osteoarthritis knees better and follow a model of care, you can actually reduce waiting lists. And so all those discussions, and there's so much literature around about, doing arthroscopies. Here we go. We'll throw in the usual one for asymptomatic knees, but people still do that. So it's actually having some of those discussions. The great stuff from the King's Fund, where that was all clinician-led, about having those conversations around, clinicians actually looking at what they're doing and working together without having to have someone come in and sort of say, oh, well, why are you using the most expensive prosthesis? Why is that one delivering an outcome just as good? So it's actually, for me, I think it is about empowering clinicians to continue to do what you do.
So I was going to say, how is it different to what should be happening in best practice at the minute?
Go, Kate. I don't think it is.
It isn't. I don't think
It's
I'm going to talk about one of the practical examples. I'm going to follow Catherine, and I'm going to talk about one of the practical examples about what's different potentially. But I think, Catherine, I agree with you entirely. It's not different, but it's placing a different lens across what we do. And the other thing that is different about this is that it's 8 priorities that the entire system is focused on. So the value in ACI being able to connect you to someone who has a similar problem, who's already solved that problem, because the entire system is focused on 8 things, is one of the strengths of this as an approach, I think. And then when the next round comes and there'll be another handful of things that the entire system focuses on together. So we're all reinventing the wheel, at our own desks often. And so I think this has that as a strength.
And so falls strategies, great flurry and attention on falls. We do really well, and guess what? It declines because we don't sustain the effort. So that's exactly. So as Kate's saying, it's about some sustained effort, systematising it, having it absolutely embedded as your usual practice. And the other bit, I will say is a bit different, is the evaluation and monitoring. So getting that information feeding back to you about what has actually happened, because often, I don't know, how many of you get good feedback about the outcome of your patients?
Nobody knows what you mean by good feedback, isn't it?
But that's so that's the difference. It's actually about having measurement frameworks, evaluation, outcome reporting, so that you actually know what the patient outcome was.